Welcome to today's continuation of the approach to acid-base disorders. And I thought today I would go back a little bit and review some of the things we've talked about just to make sure everyone is on the same page. My hope is that we can get uniformity among everybody eventually. Some people will be faster than others about approaching the question of what is the acid-base diagnosis. The trick is to rid yourself of most of your previous approaches and thoughts, and to just target in on the steps that you need. It'll simplify your thinking, and it'll also allow you to be more accurate in your diagnoses. So I thought I would just again go over the same thing until it becomes intuitive for all of you and second nature. Okay, so again, just terminology which confuses some people. And again, you'll hear residents, attendings, most of the nephrologists that you'll hear will confuse the terminology. But just make sure you're accurate in the terms you use. It'll also allow you to have a greater understanding of what you're actually talking about, rather than just using words that you've heard throughout your medical training thus far. So the first concept is that the bicarbonate buffer system is the system that we use to diagnose acid-base disorders. We don't have, there was no reason for that a priori. It's just the most prevalent buffer system. Plus, it differs from all buffers in that the acidic phase is a gas. It's actually called carbon dioxide is called an acid anhydride chemically because it combines with water to form an acid. Other acids like protonated albumin, protonated lactate, or what we call lactic acid, those are all free in solution. Doesn't matter whether you have a gas above them or not. The concentration of the proton is not dependent on anything in a gaseous phase. Whereas with the bicarbonate buffer system, it is, because it's not that the carbonic acid is in the gaseous phase, it's that the carbon dioxide that reacts with water is. And so it also depends on another organ called your lungs, which determines the carbon dioxide concentration in your blood. So it's more complex in that sense. And it evolved to be used because that factor wanted to be taken into consideration when you're assessing blood pH. If you only focused on buffers that were in blood and forgot about this volatile buffer system, you would not be able to explain changes in pH that occurred when you'd get changes in alveolar ventilation. And conversely, when you discuss any particular buffer, as far as its acid and base properties, you don't need to look at other buffers because they're all in equilibrium. So the fact that we use the bicarbonate buffer system is also nice because we don't have to then think about what the protonation is on albumin or the deprotonation or the protonation on DNA or amino acids. They're all in equilibrium. So once you define what's going on with one, you've defined all the others. Now, there is this approach that you may have heard of called the Stewart formulation that still is in vogue in some places of the world, not so much in the US, but in European countries and elsewhere. And I wrote a review article about it years ago that you might want to look up, but it goes into great depth about the controversy and the issues involved when using the Stewart approach. We don't use it, and the approach that I take and others is that it is, number one, not needed to make a diagnosis, and two, doesn't give you any additional information. But that's the subject of another talk. So once we've agreed on the fact that we're going to use the bicarbonate buffer system for acid-base diagnoses, it's important to know what makes up that system. What are the components of that system? And they're listed on the top line. The arrows refer to an equilibrium. It means that the forward reaction and the backward reaction are the same. That's what equilibrium means. And it also means that they interconvert. So you have four substances that have a carbon on them: carbon dioxide, carbonic acid, bicarbonate, and carbonate. And these things are all present, and they're all present at the same time, and they vary with the concentration of each of the other substances. So for instance, if I hyperventilate and lower the carbon dioxide concentration, everything will shift to the left. all these things will change. Now, as I mentioned a number of times, the one thing that doesn't change much is the proton concentration, because there are other protonated species in blood, other buffers that we just talked about, that deprotonate when this happens and tend to keep this fairly constant. It changes a little bit. The other thing to realize is that the concentrations of these things, which are not listed here, are very different. The carbon dioxide concentration in water is 1.2 millimolar. It's 1.2 millimoles per liter, derived from what's called the solubility coefficient, which applies to any gas as a solubility coefficient of oxygen, a solubility coefficient of nitrogen. That tells you how much of a given gas at a certain pressure above an aqueous solution is dissolved in that solution. So for carbon dioxide at 37 degrees, it's about 0.03. The units aren't important, but if you multiply 0.03 times the PCO2 of 40, you'll get about 1.2 millimolar. The carbonic acid concentration is not in the millimolar range, it's micromolar. And carbonate also is micromolar. Whereas bicarbonate is in the millimolar range, like carbon dioxide, but it's much greater. It's around 24 millimolar. The proton concentration is nanomolar. We know that a pH of 7.4 represents a proton concentration of 40 nanomolar. So it's much, much smaller than either carbonic acid or carbonate. So it's important to get an appreciation not only of the species that we're talking about, but also their concentrations. Now, clinically, we tend not to, there's no way to measure bicarbonate. You can only calculate it from the blood gas machine that measures the pH and the PCO2. So there's an electrode to measure the carbon dioxide concentration and also the proton concentration. And there's an equation you can use. You can use the full Henderson-Hasselbalch equation or a shorter form of that. The machine has an algorithm in the chip. It knows how to calculate the bicarbonate from those two measurements. And that's what you get. You get a calculated bicarbonate, and it's perfectly fine. And that's what you should call bicarbonate. You should only use the word bicarbonate when you're referring to the result from a blood gas. You should never, ever, ever, during your fellowship or thereafter, call what we get from the chemistry panel the bicarbonate. It's the total CO2 because it represents all four of these carbonated species together. Now, as I said, the carbonate and the bicarbonate and the carbonic acid are in the micromolar range, so they don't contribute to this. The main contributors are bicarbonate and dissolved CO2, with bicarbonate being the major contributor. So it's mostly bicarbonate. So in that sense, you're not usually too off when you say it, even though terminologically you're in error. The other thing you'll hear is people call this the CO2, and that is not a word that should be used either. You should never use the word CO2 as a fellow. It should either be the PCO2, which means the partial pressure of carbon dioxide when you're referring to what the blood gas gives you, or you should say the total CO2, or if you want, TCO2. But you should never, ever again use the word CO2 like many people do. And secondly, please don't call this bicarbonate. The other reason for not calling it bicarbonate is the bicarbonate concentration may be 24, but you might have much more dissolved CO2 in the blood because the patient has a severe respiratory acidosis, in which case the total CO2 will go up, not because the bicarbonate went up, but because you have a severe respiratory acidosis. So to call this bicarbonate in that sense is even further wrong. Okay, so I mentioned that the blood gas machine can calculate the bicarbonate, and it does so because it knows the relationship between the pH, the PCO2, and the bicarbonate. And there's a quick formula you can use just if you want in your head, if you want to just think about these things, where the hydrogen ion, and again, there's no units here. This is just absolute values of what the numbers are that we're used to, given the units that we typically use. Obviously, if we use different units, we'd have different numbers. But with the units we use, you can remember this simplified version of the Henderson-Hasselbalch equation, where the hydrogen ion concentration is given here in its nanomoles per liter. I mentioned the units aren't important. And the constant is 24 or 25, and the bicarbonate's either 24 or 25. Here I put 24. I probably should have had 24 and 24 here in this formula. But you can see that the PCO2 times this constant in the numerator divided by whatever the bicarbonate concentration actually is, numerically gives you the number for the hydrogen ion concentration. Now, in medicine, we don't get back a hydrogen ion concentration. We get the negative log of that. And there are a number of reasons for that, which I mentioned before. First of all, the pH electrode that measures the hydrogen ion activity in the blood, the activity or the log of the activity varies with the voltage on the electrode linearly, not the activity itself, but the log of the activity varies with the voltage. So that's one reason. The other reason is just a human reason, that humans don't like numbers with a lot of decimal points. So if you had to go around the ward saying the patient's hydrogen ion concentration was, 0.000000040 moles per liter, people wouldn't listen to you very long. So people came up or were accepted this log term, realizing that we don't use log for anything else in medicine. We don't talk about the log of the sodium concentration, even though, again, like the pH electrode, the log of the sodium activity in the blood varies linearly with the voltage on the electrode. We don't do it, and probably just because the number is a number that humans can accept. 140 millimolar or 140 milliequivalents per liter is a lot easier to say. So it's unique in that sense, and in order to then utilize this formula, you have to be able to convert hydrogen ion concentration to logs, or the negative log. Now I've sort of changed the word activity and concentration. We talk about concentration in medicine, but actually what any electrode measures is what's called the activity. It's a thermodynamic term. Okay, so in order to be able to convert the pH, which everyone is used to clinically, to hydrogen ion concentration, if you want to use that formula, or if you like thinking about it in its absolute concentration terms, which again, I think is better because it gives you more of an intuitive feeling of what the actual hydrogen ion concentration is. And that's actually what the cells are seeing. The cells don't see the negative log of the hydrogen ion concentration. That's a human construct, again, as I said, because of how we measure it. The cells are actually seeing the hydrogen ion activity. So in that sense, if you're trying to get a deeper understanding of cell biology or exactly what is going on medically, this is what you should be focusing on. So you can use this in your iPhone or whatever you want to convert. But if you want to do it in your head, a very simple rule is what's called the 80% rule, where you take a pH of 7, which is a hydrogen ion concentration of 100, and then you just keep taking 80%. So 7.1 is 80, 7.2 is 64, 7.3 is around 50, that sort of thing. 7.4 is 40. And you can interpolate in between if you want to get things, halfway. So that's sort of a quick and dirty way of very quickly converting the pH to a hydrogen ion concentration, and then going and checking this formula if you want. And it's nice to, when you get a blood gas back, to just do this. It refreshes your memory of the interrelationship. And the other main reason for doing it is that this formula here represents organ function that then leads to changes in acid-base values, because the numerator here, the PCO2 in the numerator, this thing here, the PCO2, is affected by your lungs. There's a constant production from the mitochondria, which doesn't vary much. That's what one of the products is from the Krebs cycle. But the lungs in the steady state have to get rid of it, so that the production and excretion, production by mitochondria, excretion by the lungs, are equal in the steady state. And that's what keeps your PCO2 at 40. And it's only when there's a discrepancy between these two, the mitochondrial production and the pulmonary excretion, that this number changes. And as I said, it could be that it would change with mitochondrial production. It would be like a hyperkalemic patient getting a higher potassium because you gave more potassium. In other words, we're talking about the input side. But medically, changes in mitochondrial CO2, carbon dioxide production, don't really occur to an extent that's going to make a difference. And regardless, even if the mitochondrial production, let's say, goes up when you have a fever, immediately your respiratory center in the medulla of your brain senses it and gets the lungs to excrete that extra amount. So the PCO2 essentially doesn't change at all. It's only when you have abnormal excretion, either high or low, that this number changes. So that's one reason for knowing the formula. And the second is that the kidneys are responsible for keeping this number at 25. So you can replace these numbers if you want by saying this is 25 times lung function over kidney function. So it not only allows you to remember the interrelationship, check the acid-base numbers from the blood gases to make sure that this is true, but also it represents organ function. Now, as I mentioned before, the one thing to remember is that males and females don't have the same numbers in the steady state. They have the same hydrogen ion concentration, but the components are a little bit different. The PCO2 and the bicarbonate in a female are a little bit less. And as I've mentioned before also, at mid-cycle, when a woman ovulates, the PCO2 starts to drop because of progesterone going up, and this number can be 34, 35. And in fact, years ago, people used to use the PCO2 to tell when a woman ovulated. And there's also a difference that you need to know about between arterial and venous, because often we get venous blood gases. Either you don't want to poke an artery, or you don't need to do it, or the patient doesn't want you to, whatever the reason. There's advantages to getting venous numbers. One, you can get the numbers as often as you want, usually, if you have a dynamic change in the blood gases over time. Secondly, the component of white coat syndrome tends not to occur because often you have a line in the vein, and you can just do it without the patient either being afraid because you just walked in the room, or the patient feels pain, both of which will cause an acute respiratory alkalosis. When you make an acid-base diagnosis, you don't want to know what the diagnosis is after you walked in the room. You want to know what it was prior to you walking in the room. And so to the extent that you can prevent an acute respiratory alkalosis, in addition to what was ever going on before, the better for it. And venous blood gases offer that opportunity. In general, if you're not interested in the PO2, venous blood gases suffice to make an acid-base diagnosis. You just have to really know what the normal numbers are, because remember, you're looking at changes in the PCO2 and changes in the bicarbonate from normality. So you'll have to always remember, if you don't have prior numbers in the patient from the venous side, that the average is around 43 and 26 for the bicarbonate. I don't recall, maybe one of you can find it, an article on the difference between males and females in venous blood gases. That may exist. I just never saw a paper like that. It would be actually a nice paper to write if any of you are interested in such a project. We would have to get data from UCLA, but it would be nice because you wouldn't have to get consenting from patients. We would just take numbers that already exist. So that would be actually a nice addition to the literature. Perhaps some of you can look and see if you can find any numbers like that. But it's important because we can't assume 43 necessarily is true in a female. And these numbers in the literature, actually, I'd have to go back and look at the data. Might have come from males and females. Most likely they did. So it's very possible that in a male it's even higher, and in a female it's lower than this. Same with the bicarbonate. Now, the reason the venous numbers are different is because of the fact that the cells are making carbon dioxide. So when you're taking blood from the venous side, you're actually looking to what happened when the mitochondria have made carbon dioxide in the Krebs cycle and added it to arterial blood. You end up with this kind of blood, and conceptually, it's blood that hasn't had its PCO2 brought down to 40 by the lungs. So this is sort of an experiment of nature that you're looking at. You're actually seeing what blood is solely due to the addition of carbon dioxide from the mitochondria. It's not solely due, it's added onto the arterial blood, but the additional effect is from the mitochondrial carbon dioxide addition prior to the lungs getting rid of that carbon dioxide. So what you're really looking at is an acute respiratory acidosis caused by the mitochondria in the cells adding carbon dioxide to arterial blood flowing by. And what that really does is drive this reaction to the right. So you're generating the PCO2, carbon dioxide is added, so the PCO2 goes up because you haven't gotten to the lungs yet to excrete it. And the bicarbonate then will go up a little bit based. It's the same formula as the acute respiratory acidosis formula that I've showed you. There's a very small change in bicarbonate for an increase in the PCO2. And again, this confuses people, but don't let it confuse you anymore. The hydrogen ion concentration does not go up by what the bicarbonate went up, even though if this was the only buffer, it would. So if I bubbled water with carbon dioxide and there was no other buffer, I would make an equal amount of protons and bicarbonate. It doesn't occur in the human body because the protons can attach to other buffers. There are other buffers present. There's DNA in the cells, there's amino acids, there's phosphate, there's albumin, there's hemoglobin. There's a ton of substances that we call buffers that combine protons. So most of the additional protons that are made are not going free into solution. They're binding. And so this hardly changes. So again, the PCO2 is kept constant at 40 because the production by mitochondria is equal to the excretion rate by the lungs. If some of you are interested in the amounts, we're talking about 20 moles a day of carbon dioxide are made and excreted in an average human. And it's only when the excretion is less than 20 moles a day that the PCO2 goes up. So when you say someone's not ventilating properly, or you say they have a respiratory acidosis, what you're really saying is they're not excreting 20 moles a day anymore, or at least transiently. When the PCO2 goes up and reaches a new steady state, you're back to 20 again, because now each breath contains more carbon dioxide. So the total amount that you get rid of is the same as before. It's no different than, let's say you cause the GFR to go to half. Let's say someone's creatinine goes from 1 to 2. Well, transiently, your urea excretion rate will be half. Let's talk about urea. So the BUN will start to go up. But as the BUN goes up, more is filtered per unit time. Even though the volume coming through is half normal, each volume amount is getting increasing and increasing amounts of urea until the total amount coming out is right back to what it used to be at the higher blood level. So that's a concept people need to appreciate in nephrology, that when you create a discrepancy between two things, you don't have a permanent discrepancy as long as the substance is changing with time because of the initial discrepancy. You end up with equality again, but at a different blood level than before. And that's true of potassium, sodium, chloride, anything we measure in nephrology. You get transient discrepancies of input-output that then come back to normal. So how does the kidney, so the lung is rather straightforward. It just gets rid of the carbon dioxide. And the kidney has two processes that it has to have to keep the bicarbonate constant, because it's faced with two difficulties that prevent it from being constant. One is that the bicarbonate's filtered. So every day we have a bicarbonate going through the glomeruli, 24, 25 millimolar, and a female it's 23. The GFR, well, it can vary from 130 to 150. 170 is a bit high, but let's say the typical GFR is 120 to 150 liters a day. We tend to think in mils per minute, but there's 1,440 minutes in a day. So when you multiply that by the mils per minute, you end up with about 120, 150 liters. So you think of it, that's a problem. Each liter has 25 millimoles of bicarbonate. That's about 4 moles of bicarbonate coming through all our glomeruli every day. And yet our bicarbonate, despite that filtration, does not go to zero. It would go to zero if you had nothing else happening. If we only had glomeruli in our kidneys, the bicarbonate would be zero in about 4 hours. You would deplete your whole blood of bicarbonate very quickly. And obviously that doesn't happen. So even without knowing any renal physiology or transport processes, just conceptually, you must be absorbing the bicarbonate back into the blood somehow. And that's what the responsibility is of the nephron, in particular the proximal tubule. And as I've shown before, it's an indirect process where you don't have bicarbonate transport into the cell from the glomerular filtrate per se. It's indirect via a protonation process that occurs. And there's two processes that secrete protons into the lumen. One is a sodium hydrogen exchanger called NHE3. There's 8 of these in the human genome. Won't get into that today. And then there's another entity called a proton ATPase. This is actually made, and this is not one protein. It's made of around 13 subunits, all different proteins, all encoded by different genes, and they all assemble into this machine, call it a nanomachine, that's called a proton ATPase. It splits ATP. This does not require ATP. It's totally passive. The sodium enters because you have a sodium pump on the basolateral membrane, lowering the cell sodium to about 20. Remember, inside cells in our body, the sodium is not 140. It's about 20 millimolar. And that creates then a gradient for substances that are coupled, or transporters that are coupled to sodium, to be driven thermodynamically. So sodium enters down its gradient. The pump here requires ATP, energy is required, but when the cell sodium has been lowered, now these things work, and sodium will enter, and it exchanges 1-to-1 a proton. Even though the proton concentration is in nanomolar and the sodium is in millimolar, the affinity of this thing for protons is so great that you get a 1-to-1, that even at a nanomolar concentration, you still get binding to the transporter and then transport. So 1-to-1 transport, and the proton pump splits ATP. It is energy requiring. And then both of these things send protons into the lumen. But what's that going to do? You're going to bind bicarbonate and make carbonic acid and water and carbon dioxide. You're going to drive the reaction this way. So you basically converted bicarbonate, or at least a component of it, into carbon dioxide. Well, we still haven't done anything. Now we got carbon dioxide in the lumen of the proximal tubule. How does that help us absorb bicarbonate? Well, now we've created a carbon dioxide gradient between the lumen of the tubule and inside the cell, and it will go down its gradient. Some people think it actually goes through aquaporin 1 specifically. The other important protein in this process is one of the carbonic anhydrases, and you may recall that carbonic anhydrases increase this reaction here, not the conversion to carbonic acid, but the breakdown of carbonic acid into water, carbon dioxide. It doesn't change the final steady state or equilibrium. It just makes it occur faster. So it increases the efficiency of this. It doesn't change. If you didn't have it, you'd end up with exactly the same concentrations. It just takes longer. And this is actually not in the cell. It's not in the lumen, obviously, or would be go down to the rest of the tubule. It's actually bound to the apical membrane of the proximal tubule. It's called a GPI anchored protein, and it attaches here and works just in the brush border, which you can't see here, in the aqueous glomerular filtrate. So carbon dioxide enters, and then the reverse reaction occurs. Again, we have a carbonic anhydrase. This is carbonic anhydrase 2. It is in the cytoplasm, and it does float freely around. And there are mutations in this transporter, and you need to know the phenotype. We won't talk about RTA today, but it causes a mixed type of proximal and distal RTA. So this reaction is also accelerated by this. There's this carbonic anhydrase. I think there's something like 15 or 16 carbonic anhydrases in the human genome. So these are just 2 of them. And again, you just make the reverse reaction where you end up ultimately with 2 protons and a carbonate, if you remember that first reaction. And the protons just recirculate on these things. So basically, if you think about the same proton really is going around and around and around, and you end up making carbonate. And carbonate leaves the cell on another protein that we've done a lot of work on in my laboratory. It's called MBCE1A, but it's a cause of proximal RTA in humans when it's mutated. It's one of the genetic causes of proximal RTA. It's not involved with Fanconi syndrome. You just get a pure proximal RTA. Patients' bicarbonates are 11, 12, 13, very, very low, because they can't absorb bicarbonate in the proximal tubule. Now, technically, it's not bicarbonate which is absorbed, it's carbonate. But because the carbonate, when it gets into the blood, basically took the carbon from bicarbonate, because the bicarbonate, not shown here, is what broke up into the additional proton and carbonate. Effectively, you're taking bicarbonate into the blood, and then you just get the reverse reaction occurring here, where you generate bicarbonate and then carbon dioxide. The carbon dioxide that's generated is just excreted by the lungs. So the net process here takes the carbon from bicarbonate and sends it as carbonate into the basolateral side. So this is the current thinking as to how bicarbonate is absorbed in the proximal tubule. There are additional subtleties that I won't get into today. Now, this is an electrogenic transporter, which means it carries a current, because the carbonate and the sodium are not the same charge. It actually carries a 1 negative charge. And also, as you go along in your renal fellowship, you should get the terminology of these transporters more exact. Don't call everything a channel like most renal fellows do. A channel refers to a channel. It only transports one ion, like a potassium channel. There are many of them in the genome. Chloride channels. This is called a co-transporter or a symporter. There's also exchangers like the sodium hydrogen exchanger. These are not channels. Channels transport ions much, much, much faster, maybe 10 million ions a second. NHE3 transports about 3,000 roughly ions a second. MBC1A, my laboratory has found, transports very quickly, just like AE1, the band3 protein. Around 50,000 ions are transported each second. And people now understand how that's done. So you can think of these things as little dynamic nanomachines. And they're being studied in and of themselves. And basically all of nephrology are abnormalities in transporters. So if you really want to get down to the nitty-gritty, you can stay at the clinical level, but that's not going to allow you to understand what's going on in your patients more than essentially a resident does. If you really want to get down to having a deep understanding of all diseases in nephrology that affect the nephron, not the glomerulus, then you really have to understand what these transport processes are for every ion, what the players are. Each one is a separate story, whether it's magnesium transport disorders, phosphate transport disorders, sodium transport, they all have a different set of players involved and stories, whether a given one is mutated or not, that perturb the system. So I mentioned that this is electrogenic because it's the membrane potential here on the basolateral membrane that drives this thing. This cell, like most cells in our body, have a negative or more negative inside than out. That's what the potential means. And in the proximal tubule, it's about 40, 50 millivolts, depending on the species that you measure. I don't think anyone's made measurements in humans, but in rabbits, mice, rats, it's roughly the same. And that electrical gradient is what drives this out, because the chemical gradients are in the wrong direction. The sodium in the blood's 140. In the cell, it's 20. So, you know, there's a 6-to-1 gradient for the sodium to enter, and the carbonate concentration in the blood is higher than the cell. The pH in the cell actually is not 7.4 in the steady state. The cells in our body have a pH of about 7.15, 7.2. So the carbonate concentration is lower, the sodium's lower, and yet the thing sends them both out against their concentration gradients. And all mammals have this system where the blood concentrations do not, relative to the intracellular concentrations, do not favor the absorption, but the electrical gradient out exceeds the chemical gradients in. And there's an equation that you can use called the Nernst equation to calculate the chemical gradients and electrical gradients, and then determine what direction a transporter that's electrogenic will transport. So it's important to realize that this thing requires a normal membrane voltage on the basal. And there are some there are some models where there's a potassium channel here, and when it's mutated, you lose the voltage. Or if the sodium pump gets perturbed clinically, you're going to affect proximal tubule bicarbonate absorption. So just something to keep in mind. This is how the bicarbonate that gets through the glomerulus, the around 4 moles a day, to a great extent are absorbed, since most of this absorption occurs in the proximal tubule. Now, there are other nephron segments. The thick ascending limb, where Lasix works, absorbs about 15%, and the collecting duct maybe another 4 or 5%. But the majority of the bicarbonate absorption occurs here. That's why we don't have a term for RTA for the thick ascending limb. We have proximal RTA because when it's perturbed, we lose a lot more bicarbonate. But conceivably, we could lose thick ascending limb bicarbonate transport, but if your proximal tubules function normally, you're only going to lose 10 to 15% of the bicarbonate transport. So you're not going to really see it clinically. And if the collecting duct loses its bicarbonate absorption, we don't have a term for that either. We don't call that collecting duct like proximal RTA or some other term. Distal RTA is totally different. It has nothing to do with bicarbonate absorption. So the major player for bicarbonate absorption is the proximal tubule. The other thing the kidney has to do is to counter this problem, and that is every day in our diets, we make protons. The liver makes hydrochloric and sulfuric acid around 50 millimoles a day and pours it into the hepatic vein. It's as if you had started a hydrochloric acid drip. You're doing it right now when you're eating 3 times a day. Your liver's pumping acid into the hepatic vein. The bicarbonate in the hepatic vein is lower than systemic blood, systemic venous blood even, because the hepatic venous blood is acidified by this process, and that venous blood then gets into the venous system and then mixes with the arterial blood. And if this was the only thing that was occurring, your blood bicarbonate would be 0 in 2 weeks if you just kept having this proton load without anything else happening. Even if you have normal proximal tubule bicarbonate absorption, the blood bicarbonate that the kidney needs to absorb would keep falling and falling and falling. So even with perfect proximal tubule reclamation, your blood bicarbonate would fall because you have this proton load, which has nothing to do with proximal tubule bicarbonate absorption. And in fact, it's known that different diets can be divided up into acid or base producing. So it's not just that you can produce acid from your diet, like if you eat a lot of cheese or egg yolks, meat, poultry, fish, but you can also make net bicarbonate from your diet if you eat raisins and spinach all day. Then you don't have a proton load. That's easy to take care of because the bicarbonate that's made is just excreted by the kidney. Once the kidney gets above its 25 millimoles per liter absorption, it just dumps the rest. So that part's easy. It doesn't keep absorbing that excess normally. But if you eat these kind of things, your proton load can be not 50, but 100 a day. And so you have even more of a problem. The typical North American diet's around 40 or 50. So you can think of yourself and where you are on this spectrum. Some people think that's important because they attribute bone loss with aging to proton input from your diet not being taken care of properly by the aging kidney. So the protons that come into the blood, something must be done. If nothing's done, those protons are going to go everywhere. And one place you don't want them to go is your skeleton, because then they're just going to exchange with calcium, and you're going to have less calcium in your skeleton. And some people think that that's one of the reasons for osteopenia as you age, that the kidney itself cannot compensate for this. So what does the kidney need to do to compensate for this? It needs to do something to prevent this proton load from being isolated by itself. And what it does do is it generates bicarbonate above what it absorbed. So it generates around the same amount of what we call new bicarbonate, because this is not bicarbonate from the glomerular filtrate. It's additional bicarbonate that the kidney is generating beyond what it reclaimed from the glomerulus via the processes I just showed you to match the daily proton load. So it's as if the liver is a proton IV with hydrochloric and sulfuric acid, and the kidney is a bicarbonate IV. And those two rates roughly are equal. You will generate carbon dioxide, just like occurs in the pancreas, right? Your stomach is putting a ton of protons into the duodenum, and the pancreas is putting in gallbladder, put a solution in with a very high bicarbonate concentration. I'm not sure you're aware of that. The bicarbonate concentration in bile, pancreatic juice, can be over 100 millimolar. It's way higher than blood. So what occurs all the time in your duodenum is these two different solutions are mixing, and you make carbon dioxide, and the carbon dioxide gets absorbed via the duodenal cells and is excreted by your lungs. But this same thing occurs at a much, much slower rate via this other process where we have a proton load and a bicarbonate load making carbon dioxide. And again, it's the proximal tubule of the kidney that does most of this new bicarbonate generation. And it does so mainly from the amino acid glutamine, which it takes up into the cell, converts it in the mitochondria into alpha ketoglutarate. And then the alpha ketoglutarate enters the Krebs cycle. Also, it can occur via gluconeogenesis, but mostly the Krebs cycle, where two bicarbonate ions are made. This thing has two carboxyl groups on it. And when they're neutralized in the net process, two bicarbonate ions are made. So this is how a typical human makes new bicarbonate. And then this just goes via NBC1A, like the filtered bicarbonate does, back to the renal vein. The issue with this process is, though, one of the byproducts is two ammonium ions. So for every two bicarbonate ions that are created, we also make two ammonium ions. Now, why is that important? Well, number one, that's where the ammonia comes from in your urine. It's coming mainly from glutamine that's metabolized in the proximal tubule. So when you see ammonia in the urine, you should now start thinking, oh, that's something that was coupled to the new bicarbonate that the kidney made also. People don't think of that. But the key question is, if the ammonia that was made in this process in the mitochondria was sent only to the renal vein with the bicarbonate, so let's say the ammonia that's here with the bicarbonate, both were put into the renal vein, what would happen? Why should that not be occurring? The reason is you would just consume all that bicarbonate in the urea cycle. Urea comes from two ammonia and two bicarbonate ions. When you summarize the urea cycle stoichiometry, that's where urea is derived from. So if you took glutamine, broke it up into ammonia and bicarbonate in the proximal tubule, and then sent both into the renal vein, you would just make urea, and you would have done nothing as far as acid-base balance. You would just be converting glutamine into urea, but you would not be generating new bicarbonate to match the daily hepatic proton load. So you would just think intuitively that maybe the ammonia is not sent into the basolateral side. Maybe the ammonia is sent into the lumen, and then the kidney just dumps it. Why is any ammonia sent back? Well, it turns out that that's almost true, but not totally true. So here's a proximal tubule, a scanning EM of one proximal tubule. This is the basolateral side where NBC1A is. This is the apical side where the brush border is and NHE3 is. The bicarbonate is filtered through the processes I showed you, is sent as carbonate to the basolateral side. That's how bicarbonate's absorbed as carbonate. And the bicarbonate then gets to the renal vein, and that's great. Ideally, we'd want all of this to match the daily, or contribute to matching the daily hepatic acid load. Well, it turns out that the ammonia is not all sent to the renal vein. Maybe 40% of it is. The rest is sent to the urine. So 40% is counterintuitive and is sent to the renal vein, and you lose 40% of the bicarbonate you've generated here. So if you make 100% bicarbonate from alpha ketoglutarate, and that was the only process, let's say, you would end up with 60% of the bicarbonate that you could have had to match the daily hepatic proton load, because 40% of that bicarbonate was turned into urea and is basically a futile cycle. You've turned 40% of the glutamine into urea. And that's what we all do every day. We don't send all of it into the urine. The rest of it goes into the urine, and it ends up in the collecting duct from NHE3 getting into the collecting duct. I won't talk about how ammonia gets from the proximal tubule into the collecting duct. That's a complicated process. But just remember, all the ammonia that you have in the urine when you measure it is coming from proximal tubule production via a complex series of internephron transport processes that allow it to end up in the urine. And the ammonia actually goes through these two RH proteins. We know the RH blood diseases. Well, there's RH proteins in the kidney also, and other organs, and it turns out these are ammonia transporters. There's controversy as to whether it's an NH3 or NH4 transporter. Many people think RHBG is an NH3 or NH4 plus transporter. Others think RHCG is only an NH3 transporter. But the bottom line is ammonia gets into the collecting duct, comes out into the final urine. How it does so, we'll talk about another time. And that frees up, 60% of the bicarbonate to now be able to match the daily hepatic proton load. Okay, so let's now go a little more clinical, just to review. When someone says to you, what's the acid-base disorder? Like a laser, only look at the bicarbonate or the total CO2. Don't say or look at anything else. Just the bicarbonate or total CO2. If you don't do that, make yourself do that so that it becomes second nature to you. Don't talk about pH. Don't talk about the clinical situation. Don't talk about the mechanisms, how the acid-base numbers could have changed. The answer to the question of what is the acid-base diagnosis should be answered by first saying, I'm going to look at the bicarbonate and I'm going to decide, is it increased, normal, or decreased? If it's decreased, you have one of three choices. It's either metabolic acidosis, acute respiratory alkalosis, or chronic. Remember, typically to say acute first, some people say chronic first, but if you do that, you're not thinking logically because the acute comes before the chronic. You can't have chronic without first having the acute. It's just that it was converted into chronic. So again, bicarbs decreased, or again, total CO2 if you don't have blood gases, metabolic acidosis, or acute or chronic respiratory alkalosis. They are different because they have different changes in bicarbonate from normality versus the PCO2 from normality. This is about 1-to-1. The change in the PCO2 relative, this is the initiating event, so I'll mention it first. The change in PCO2 relative to the change in bicarbonate is 5-to-1 or 10-to-2, whatever you like to measure or remember. In chronic respiratory alkalosis, the bicarb falls further, another 3. So you had the initial fall of 2, and then you get over the next 2 or 3 days a further fall of a total of 5 for if the PCO2 has fallen by 10 such that nothing else happens, just stays there. So 2-to-1. So these two can be differentiated very easily. This is around 1-to-1 and this is 2-to-1. So if you see 2-to-1, it cannot be a compensation for a metabolic acidosis. The PCO2 has fallen twice with the bicarbonate film. And this clearly can't be either because the change in the bicarbonate is so little. If the PCO2 fell by 10, the bicarb's only fallen by 2. And it obviously can't be a compensation for a metabolic acidosis when these two numbers should have changed roughly equally from their original levels. Or the bicarbonate may be elevated. So you say to the person, what's the acid-base diagnosis? They ask you, say, well, I'm going to look at the total CO2 or bicarbonate, and I'm going to decide if it's normal, increased, or decreased. It's increased. Again, one of 3 things. They both have one of 3 choices. So even if you don't know what the 3 choices are, at least you should remember there's 3 possibilities for each. This is the opposite direction. So it's metabolic alkalosis or acute or chronic respiratory acidosis. Again, you have to memorize this formula because it's not roughly 1. It's a little different from 1-to-1. For every 7 increase, 10 increase in the bicarbonate, the PCO2 goes up 7/10 of that, not quite 10. If they were equal, then it would be 10-to-10 or 10-to-9, similar to what the metabolic acidosis is. They're more equal. In metabolic alkalosis, the PCO2 doesn't quite go up with the bicarb went up. And again, in acute, you've got this huge discrepancy between the two, where for every 10 increase in the PCO2, the bicarb goes up about 1. If you maintain that, it goes up another 2.5 above its original level. So again, mention acute respiratory acidosis first because it had to have occurred if the patient has chronic. And so just logically, you're converting this to this temporally, rather than mentioning this first and saying, oh yeah, it could also be acute. That's fine. You're not missing a diagnosis, but it's more aesthetically pleasing if you mention this first before this. So each of these are divided up into 2. We just said the respiratory acid-base disorders are divided up into acute or chronic. But we haven't talked about how metabolic acidosis and alkalosis are divided up beyond whether they're compensated or not, because there's a further subdivision. So metabolic acidosis can be either normal or elevated anion gap. Metabolic alkalosis could be chloride resistant or sensitive. So for metabolic acidosis, you have to say 4 things. And metabolic alkalosis, you have to say 4 things. You have to say, let's say you think it's a metabolic acidosis. You have to say whether it's compensated or not compensated. And you have to say whether it's an elevated or normal anion gap. So each of these things can be compensated or non-compensated. And the same with metabolic alkalosis. It could be chloride resistant or sensitive, but each of these could be compensated or not compensated. So it's insufficient just to pick, 1 or 2 of the 4 for these. You have to say all 4 in order to have a complete diagnosis. Now, taking that even further, I've said a number of times that saying it's uncompensated or not compensated properly is also not sufficient, because when you say metabolic alkalosis or acidosis are not compensated properly or sufficiently, if you want to use that word, you're also saying by definition that there's a respiratory acid-base disorder present. So again, if someone has ketoacidosis with a bicarbonate of 15 and the PCO2 is not 30, in other words, the changes are not roughly equal, let's say the PCO2 is 35, it's not sufficient to say the patient has an anion gap, elevated anion gap metabolic acidosis that's not compensated properly. Yes, you're right. It's not compensated properly. It's 35 instead of 30, the PCO2. But you should also be saying my patient has a respiratory acidosis. Because remember, the lack of the appropriate compensation means, by definition, the PCO2 isn't what it should be. And if the PCO2 isn't what it should be, then the next logical thought is you have to have a respiratory acid-base disorder. That's what it means when the PCO2 isn't what it should be. Now, it doesn't tell you if it's alkalosis or acidosis. That depends whether the PCO2 is above what you'd expect for the compensation or below. If it's above 30, then anything above 30 is respiratory acidosis in that situation. So bicarb 15 due to ketoacidosis, PCO2, anything other than 30. I mean, if it's 31, we're not going to split hairs. But if it's 33, 34, 35, 36, 37, even 40, which you would say, oh, that's normal. No, that's a respiratory acidosis because it should be 30. The ventilation is not right. That's what you're saying to some other doctor when you're saying they have a respiratory acidosis. You're not only making an acid-base diagnosis, you're telling someone that physiologically or medically there's something wrong with their ventilatory system, either lung, brain, whatever it is. So please be complete in what you're telling someone with these two. These two are a little more easy in that they're just divided into acute or chronic. And people forget that also, by the way, even though it's more simple. They just say respiratory acidosis. That's fine when you're a medical student and resident. It's not fine when you're a renal fellow. You have to say it's acute or chronic, or neither. It's in between, as we talked about last week when we talked about things that are not steady stated out yet, but you pick the patient in between reaching the final steady state. But there's no division by chloride sensitivity. There's no division by anion gap. Okay, so here's a patient, and you can read the clinical history here: cramping, weakness, fatigue, admitted 3 times because of dysnatremia, hypokalemia, and metabolic alkalosis, and was treated with salt tabs, potassium, IV fluids with a little bit of improvement, but not a lot. And patient was hypotensive, no edema, and these numbers were drawn. So the patient is dysnatremic, hypokalemic. The total CO2 here is elevated. We'll calculate the anion gap here, and it looks normal. And the creatinine is elevated here. So there's some, we don't have a BUN, but there's some dysfunction here. We don't know how long it's been going on either with the GFR. And venous gases were drawn, and you can see the numbers. The calculated bicarbonate's 37, and the PCO2 is 52, and the pH is 747. So the urine soda, this looks like, it probably, based just from the history and the hypokalemia, you're thinking even without those numbers, even though it's not the best way to go, that there's probably a metabolic alkalosis here. And again, you got the urine chloride. But if you just look at the numbers, again, the bicarb's elevated. It's either metabolic alkalosis or acute or chronic respiratory acidosis. Well, it's not acute respiratory acidosis because the PCO2 has gone up 12. The bicarb should go up 1.2. Obviously, it didn't do that. Metabolic alkalosis, the bicarb's gone up 12. So the PCO2 should go up 7/10 of 12. Right? So it should go up 8.4, and it didn't. It went up by more than 8.4, went up by 12, roughly. I mean, it's venous gases, so it went up by 11 or so. We don't know exactly what or nine, let's say the PCO2 was 43. So again, it gets a little more difficult because on the venous side, you have to think that the bicarb didn't also go up by 12. I mean, the venous bicarbonate's probably about 26. So if you want to be very strict and exact with the numbers, you start off with 26. Again, we don't know male-female differences, but 26 going to 37 is 11. So the PCO2 should have changed 7/10 of 11, which is 7.7. And if the PCO2 started at 43, it went up by 9. So it went up more than you would predict, even if you think about all these other subtleties. So if it's a metabolic alkalosis, there's got to be a mild respiratory acidosis in addition. Could this be chronic? It can't be acute respiratory acidosis, the second possible reason for an elevated bicarbonate, because that's 10-1, right? The bicarb went up way too much for the PCO2 going up. But could it be chronic respiratory acidosis? Well, again, for every 10 increase in the PCO2, the bicarb goes up 3.5. So if the PCO2 went from 43 up to 52, that's 9. So it should have gone up about 3.4, let's say, above its original level. If it started at 26, it should be like roughly 30. So this cannot be chronic respiratory acidosis. So we've ruled out acute and chronic respiratory acidosis. We've ruled out actually all three. So we know it's a mixed disorder. So just given the history, given the dysnatremia, the hypokalemia, and the and what's going on, as far as a mixed disorder, it's either going to be metabolic alkalosis with a mild respiratory acidosis. The PCO2 is a bit higher than we'd expect just for the compensation. If it's chronic respiratory alkalosis, you could approach it that way too. If it's chronic respiratory alkalosis, the bicarb's higher than you predict, you also have to say there's a metabolic alkalosis present. So it really doesn't matter how you approach it, either starting off that there is a metabolic alkalosis and what else must be going on, because it can't be a simple metabolic alkalosis, or you start off with a chronic respiratory acidosis as a third reason for an elevated bicarbonate. But again, you do the rules and it can't be that. So what else could it be? Well, you got the bicarb's higher than you would predict. So yeah, again, you end up with the same sort of final idea that this must be a respiratory acidosis and metabolic alkalosis. The only difference between the two routes that we followed is in one, the metabolic alkalosis is major and the respiratory acidosis is minor. And then if you start off with the chronic respiratory acidosis causing it, you end up with a greater degree of respiratory acidosis and a lower degree of metabolic alkalosis. So it just depends where you start, but you end up with the same two acid-base disorders. So that the thinking should be that, again, bicarb's elevated, it's not one of the three, it has to be mixed. Then what do you do to assess the mixed? Well, you hypothesize one and then you add another. That's how you do it. So, and we'll go into that in greater detail. We haven't really talked about what do you do if it's not one of the three, other than if it's a temporal reason because you haven't reached a steady state. So don't worry if that wasn't as clear as it could have been. So we think the patient has a metabolic alkalosis and a respiratory acidosis. The urine chloride less than 20 is compatible with that. So what's the diagnosis? Again, metabolic alkalosis and respiratory acidosis. In a metabolic alkalosis, no matter what the type, remember, as I said before, you have to calculate where the bicarbonate came from and why isn't the kidney dumping it. The second one is something people forget, but just think what happens normally. If I give you a bicarbonate IV, your kidney dumps it. It's very hard to raise the bicarbonate with a normal kidney by giving, you can only raise the bicarbonate if you're GFR, if you have CKD or ESRD. But if you have a normal kidney is very efficient at dumping the bicarb and keeping it at 25. Same thing as I said, if you eat, raisins and foods that generate bicarbonate, you don't have a metabolic alkalosis from that. It's because your kidney is dumping the bicarbonate. So people who eat raisins and those kinds of foods have a higher pH in the urine and a slightly higher bicarbonate in the urine. That was just bicarbonate that was dumped. So where did it come from is called generation, and why is it not being gotten rid of must also be thought of. So the bicarbonate concentration increases with or without bicarbonate in the body. That's one reason people give. So loss of water around a fixed amount of bicarbonate. That is not a great reason, even though you'll hear some people say that. It's a concentration issue. So like you don't see that in diabetes insipidus, for instance, central and nephrogenic. You don't see an elevated bicarbonate. Why not? I mean, theoretically, you see hypernatremia. Why doesn't, and the chloride goes up, why doesn't the bicarbonate go up? And it doesn't go up, even though you would think you would concentrate everything in your blood by the same percentage, because there's other factors that keep the bicarbonate constant in that situation that hasn't been well studied, and there's no time to get into today. Just to say that loss of water around the same amount of bicarbonate in your blood is not an important medical reason for why the bicarbonate concentration went up. It's much more common clinically to have the bicarbonate go up as a reason for the initial reason, not why it's not being gotten rid of by the kidney, but why it went up in the first place, because of bicarbonate being added to the blood. And it does so either from the stomach or the colon in clinical situations. So it's typically associated with chloride loss, and then equimolar amount of bicarbonate is added via the colon or the stomach on what we call a chloride bicarbonate exchanger. Again, it's not a channel. It's the same type of exchange process that I showed in the proximal tubule with sodium and a proton. It's called an exchanger. It falls under the category of a transporter. Transporters are not channels. Now, why doesn't the bicarbonate come out? I've shown this before. One is that you have pre-renal failure if you're volume depleted in the clinical scenario that created the metabolic alkalosis or vomiting, let's say. The proximal tubule doesn't absorb its normal amount of bicarbonate. The processes that I showed you are revved up. So the proximal tubule now is capable of absorbing a greater amount of bicarbonate than it does normally, and it takes that extra amount coming through and absorbs it. There's also decreased pendrin mediated bicarbonate secretion. Remember I said that the collecting duct has transport processes that can absorb bicarbonate, maybe 4 or 5% of the total kidney. But as we've mentioned before, the collecting duct also secretes bicarbonate. It's not something people talk about clinically, but it's extremely important because it's part of the generation of metabolic alkalosis, and it's part of the therapy of why giving chloride makes the bicarbonate come down. Pendrin is also a chloride bicarbonate exchanger. And what happens is, in order for the bicarbonate to be secreted from the blood, it's on the apical membrane of what are called type B intercalated cells, but apical means the urine side. It sends bicarbonate into the urine in exchange for chloride, but it can't work unless there's chloride in the lumen of the collecting duct. And in people that are vomiting or have extrarenal chloride loss, the luminal chloride concentration gets very low here, and pendrin shuts off. The reason it's called pendrin is because it's involved in a disease called Pendred syndrome, Pendred. It's a thyroid disorder because this transporter also is involved in iodide transport in the thyroid. But there's also a utility for the same protein in the collecting duct where it functions not with regards to iodide, but with regards to chloride absorption and bicarbonate secretion. But it'll only work if there's chloride in the urine. And so if you have extrarenal chloride loss, and you know empirically, you measure the urine chloride in some of these patients, a vomiter, for example, the chloride is very low, then your brain should immediately think Pendrin is not seeing chloride. And that's why my patient's bicarb might be high, because I'm not getting bicarbonate secreted into the lumen. And if I give chloride, I'm going to replenish the collecting duct with chloride, and now Pendrin will start to work, and the extra bicarbonate that's in my patient with the metabolic alkalosis will now get secreted into the collecting duct and it'll end up in the final urine. So it's part of the therapy also. So this patient acknowledged she had frequent mucinous bowel movements. The stool was measured. It had a sodium of 86. That's high. You should start getting used to stool electrolyte measurements too, because it's going to be important in some of the things you might see clinically, even though they're rare, but it's something that you should, as a fellow, try to master. So the sodium's normally around, in this patient, was 86. It's high. The potassium, a little bit low, and the chloride was very high in the stool. The osmolality was normal. We calculate a stool anion gap, and that's something you should get used to doing also, by taking 2 times the sodium plus the potassium minus the osmolality, and you end up with 42, and that's a bit low. The normal is 50 to 100. And the thinking is, if the stool osmol gap is less than 50, then you have diarrhea from an electrolyte transport problem. It's called a secretory diarrhea. So you shouldn't just say my patient might have a secretory diarrhea. You should know the definition chemically, how to say that. And you can say it with certitude. If it's less than 50, it's an electrolyte abnormality. But if the gap's over 100, then it's an osmol mediated. It's a substrate osmol, like a laxative, that is inducing the diarrhea. It's not from ion transport. So it helps differentiate the two. So colonoscopy was done, and a villus adenoma was found, and it was resected. Patient received an end colonoscopy. It's actually something that was first published in 1954. You might have heard of the term villus adenoma. After the surgery, this is shown here what it looked like. After the surgery, all the symptoms resolved. And most villus adenomas of the colon actually cause a hyperchloremic metabolic acidosis. That's something you need to remember. Because remember, diarrhea tends to cause a metabolic acidosis, non-GAP. And certainly small bowel diarrhea does that. It's just that with the colon, when you get colonic-induced diarrhea, it can be either metabolic acidosis, non-GAP, or metabolic alkalosis. So the colonic can be either the small intestine. If it's small intestine, it's not going to be metabolic alkalosis. So typically, you get large volumes of potassium and bicarbonate-rich fluid if it's a colonic villus adenoma. However, a small subset of these things secrete chloride, and they result in a metabolic alkalosis. So it's just an interesting case to remember. The respiratory acidosis, unclear why there was an additional respiratory acidosis. Remember, we don't use the word superimposed respiratory acidosis. We don't call it secondary respiratory acidosis. We just say the patient had a metabolic alkalosis, and we use the word and, a respiratory acidosis. We don't prioritize which came first or which was more important. Typically, we just say they're both there. That's the acid-based diagnosis. Okay, I think because of the time, I'll stop there today and take any questions if any of you have any.